Yeah, I'm not going to get through the entire talk, but one thing I was interested in, two things actually from the prior presentation was one, Clem created the Regenstrief medical record system as a modular system. So he's probably happy to hear that modular term come back up in this more advanced version. And then the second thing is, as I understand it, the patients in Kenya, when Bill and the gang, Dr. Mamlin, were first there, they used to carry their charts around on a paper record. The patients used to carry them around. So to see this more advanced version, it's just really pleasing, and congratulations. So I'm not gonna go fast, but I mean, I'm not gonna get through everything. I don't have any conflicts of interest. But basically, I wanted to go through some definitions that can be confusing, talk about some basic calculations of medication adherence and problems, and some solutions at least we've come up with. And then the part I may not get to is the study design concepts and some of the work that we've done in the past. I'll get through a little bit of it though. So Surgeon General Everett Koop appropriately stated that drugs don't work in patients who don't take them. Pretty obvious. Another surgeon, John Urquhart, who trained at the University of Pittsburgh and created a company, he got distracted from surgery, went on to create a company called Ardex in the Bay Area. He added this, they work weekly in patients who emit many doses, and some drugs can probably trigger unusual, sometimes harmful effects when dosing suddenly stops for a number of days and then abruptly resumes, which are drug holidays. So these are some of the common terms that we have. Medication possession ratio simply is the amount of drug that the patient has access to. And it used to be that we did a very good job in supplying our patients with drugs. In fact, we've gone into their homes, probably 300 homes, back in the 80s when some of the high-rise clinics were started at Luger Towers and Barton Health. And actually got an idea of how much patients keep in their homes in terms of drugs. We had them bring all their drugs out, lay them on a table, and it was just amazing the tonnage of drugs that patients had. Now things are better because computer systems for addressing prescription amounts are much better as well. But that's medication possession ratio. We did a good job of supplying our patients with drugs. Refill adherence basically covers the period from when the patient first got their prescription and when it ended. And there's different ways to calculate that. One is called the proportion of days covered. That takes into consideration the starts and stops of different drugs along the course of time. And then persistence is simply the duration the drugs used. So again, we're talking about drug use over time. Patient gets a prescription, and that prescription usually has an end to it unless it's a chronically used medication. But the patient has to accept that position or prescription, and then they may discontinue it earlier than what the physician had hoped for. So that period of acceptance and discontinuation is called execution. So that's basically the time period the patient was getting the medication. Persistence is a term you'll see in the literature, has to do with just simply the duration the patient is on the drug. And it could be shorter than what the physician hoped for. So collectively, these things are called adherence or compliance. Usually they don't use the word compliance these days because it was too paternalistic, where you should use this drug and you don't have any other options, kind of thing. So they thought that adherence was a little bit of a softer term. I'm not sure it makes a big difference, but there's a variety of motivations along the course of this execution period. Physician, nurse, and pharmacist collaboration with the patient, disease understanding, targeted interventions that ones like we have done in the past, word of mouth, and then direct-to-consumer promotions. Now these direct-to-consumer promotions can work the other way too. If you notice, some of them have, you know, a dog, emu, or you know, a happy-faced type of framework in a very nice atmosphere. But then they get into the, well, this may cause death, your arms fall off, etc. So patients respond to those kinds of things as well. Word of mouth, including what neighbors take. You'll hear people share information, and some of it's bad information. And then simply disinterest in taking the medication any further. Now, in terms of measuring adherence, patient report is important. Tom Inouye developed one of the early patient self-report instruments, a very simple instrument that we've used and really liked it a lot. More recently, Mariski has developed a instrument, and it's gone through revisions, so it's more commonly used for patient report. Pill count, we've used pill count in the past, and it's very cumbersome, and patients will often dump their pills before you get a chance to count them if they know you're counting them. So the way that we got around that is by giving them extra medicine, extra pills. So if they come up empty, it's likely that they wind up dumping them. That's a very difficult way to do adherence, but we've done it. Refill adherence, again, is basically we get at data in the INPC, the SureScripts data, and calculate these snippets over time, these arrays of use of different drugs. Could be a single drug that we look at, or if it's a category of drugs we might be interested in, like cardiovascular drugs, we'll collapse those into one type of estimate. And then electronic monitoring is an approach that we've used in the past, and I'll show you an example of that. Now, this is an example of the medication possession ratio for asthma drugs. This is from a retail pharmacy setting in North Carolina when I was there in the mid-2000s. But I wanted to point out here, this is 100 here, it goes 0 to 100. So you have this long tail. Then the question is, what do you do with that? The patients certainly were supplied with enough drug to take, and if you assume that they aren't taking an oversupply, a lot of investigators will truncate that at 100, and or you can try to transform it in some way, but the data transformations are very tricky. So if you truncate it at 100 and you still want to use the data beyond 100, you have the Brontosaurus effect. So you have basically this normal curve and then a neck. And if you don't know what a Brontosaurus is, this is a Brontosaurus. So one way around this is to decide on a cut point in which you want to say, if a patient took 80% of their drug, that's probably enough. So basically, 80%, as it turns out, is a commonly used cut point. Rick Hansen was one of my faculty members at North Carolina in our department, And he took some of the data that we had for our cardiovascular studies and looked at this systematically for self-report and refill adherence. And the gold standard here was MEMS adherence, this electronic monitoring adherence. And he found that 80% was a reasonably good trade-off between specificity and sensitivity. But for refill adherence, the estimate was a little bit better, actually much better. And but 80% seemed to be a reasonable cut point still. So that was kind of good news for us and allowed us to use that and point to this study as the reason for using it. So this is a MEMS lid. It's a computer chip and a battery that's in this lid that fits on a prescription container. And basically, this collects both a time and a date stamp every time this lid's open. So over time, you can have up to 4,000 events. And those are downloaded on this blue reader. And basically, you wind up with two types of adherence that you can calculate. One is taking adherence, the amount of the patient took over a period of time. And the other thing is scheduling adherence. So the time-to-time variation in when people take their medications. And for many drugs, that's a helpful estimate to look at. So one question I had, if you're in your 20s, so we'll say 30 years of age or less, I want to ask you a question to see if you know what this thing here is. Right here. Anybody know what that is? It's less than 30 years old. You have to be less than 30. What is it? What is it? Yeah, it's a film canister. They used it here for perspective, but if you're a younger person, you don't know what the heck that thing is. So anyways, I think those are all in days gone by, maybe fortunately so. So we've done a number of heart failure studies looking at adherence, and Veronica Bondersky, when she was here a couple of summers ago, as one of our research student interns, captured all this information that we had done over 25 years of heart failure adherence studies and put it in this publication. But one of the reasons we picked this area is what we found was it's very confusing for patients to understand all the terminology that they're hit with when it comes to medications. Like a physician may say, we'll talk about your benazepril. They may call benazepril their ACE inhibitor, or they may call their Lasix a water pill. So there's heart pills, water pills, and different generic and brand names. A very confusing picture for the patient. So health literacy becomes an important issue here. And so health literacy can play a role in adherence. And that's what we found when we looked at 150 patients with heart failure, that using a commonly used test of health literacy, those with adequate health literacy had much better medication adherence than those with marginal or inadequate health literacy. Now, one of our fellows that was with us a number of years ago looked at refill adherence in relationship to outcomes events like hospital admissions and emergency department visits. You can see here for refill adherence less than 40, admissions were much, much greater. And there's a bit of a trend here that's significant for those that take greater amounts of their medications. So that's the refill adherence to annual rate. Now this looks at a instrument that we developed back in the late 70s. when I first came here and did some work over in the clinics on the in the high-rise apartments. We asked the patients to read a label, and the advantage of that was that we could get an idea of their literacy in terms of their health literacy, but also their numeracy. So because pills, you take 1 or 2 a day, et cetera. So those that got no answers right had a much higher rate of admissions and ER visits than those that got either a partial or all of the information right. So that's the relationship between health outcomes and health literacy that we found. Now, Carol looked at this for cardiovascular and heart failure admissions, or actually these are emergency department visits, and found that after adjusting for New York Heart Association classification, which is a functional heart classification, things like good adherence, ability to read the label, were favorable predictors of fewer emergency department visits. And for heart failure itself, years of education, again, that has to do with health literacy and knowledge of the dosage, which has to do with numeracy, were favorable predictors. And it was a smaller study. So we started looking at this and developed a program around some work that we had done with a cognitive psychologist who's now a chair of a psychology department at University of Illinois, Dan Morrow. And we developed some icon-based programs that allowed us to attach glyphs or icons to prescription containers. And unfortunately, I am out of time, and I don't want to interfere with your time. But what I might do is see if Jasmine will have me back some other time to cover the remainder of my presentation. So thank you very much.